revisited PFA. This is my bio, my disclosures. And I will be talking this morning about this outline. Why zero fluoroscopy data for RF, and then moving on to PFA from the perspective of fluoroscopy reduction and elimination, and then finally future directions. We all understand that atrial fibrillation is the most prevalent arrhythmia worldwide, and it's in fact growing as the worldwide population continues to age. And this, I apologize, the picture here didn't come out correctly, but before zero fluoroscopy ablation was achieved, we had mapping techniques and interventional techniques derived from interventional cardiology. So that's fluoroscopy based, which is not ideal for intracardiac non-vascular procedures. And as our case volume has increased over many years, we increase our radiation exposure, and increased complexity of our procedures, especially for AF and VT, reveals the limitations of fluoroscopy. And then you counter that with the principle of ALARA, which is as low as reasonably achievable, which is the guiding principle of radiation use in medicine. We have, I think, a very compelling reason to continue to work towards eliminating the use of X-rays and radiation. Here's some examples from the patient perspective. At the top is a case that I show often, which is a patient I was referred to who had a prior ablation where 90 minutes of fluoroscopy was utilized, and the patient has permanent skin injury. If you look at compiled data on the bottom of radiation exposure per minute, you see that there's a significant increase across both male and female patients of various malignancies with more and more X-ray exposure. And from the physician and operator standpoint, there are not only radiation exposure risks, but also orthopedic risks if we wear lead all the time. Various surveys have identified significant orthopedic issues among operators and staff in both EP and interventional cardiology. Again, this is the same picture that didn't work out, but the problem also is that when you look at X-ray as a gold standard for mapping, we don't really see as much as we think we do. First of all, it's not real time because you don't have continuous fluoroscopy, and second of all, it only provides global tissue edge imaging and not any relationship between the instrument and the tissue contact. So what has changed the field, I think, in the last decade or so has been widespread adoption of both mapping systems and intracardiac ultrasound. These two tools in combination have allowed us to move towards a complete elimination of fluoroscopy. I created a little timeline to talk about how this has progressed. So from the start, when ICE was first developed way back in the 1980s to when the first mapping systems were developed in the 1990s, after that, the first cases of ablation using first TEE in the late 2000s, and then after that, first cases of AF ablation, and then our multi-center registry that has demonstrated across multiple institutions safety, and then finally, most recently, the FDA in the US has approved a mapping system and ablation system for zero fluoroscopy ablation, and that's guided or helped by all of this technological advancements that we have had. And then, of course, I added at the end here, and then now we are getting to the PFA era. So I'm going to just spend a couple of quick slides to review because everybody, I think, probably has seen this information before, but pulse field ablation briefly is high energy, very brief electrical pulses that disrupt lipid cell membranes. A loss of membrane integrity leads to cell rupture and then permanent death. And then there's non-thermal ablation that's involved as the energy mechanism compared to RF and cryoablation. There's also theoretically myocardial selectivity, so that theoretically lowers the risk of collateral injury. And many of the catheters that are available and in development have multi-electrode, primarily bipolar ablation delivery to promote what people like to call a one-shot delivery. So for example, when you look at tissue specificity for PFA, the threshold for permanent injury for electroporation is significantly lower in myocardium compared to other tissues that are nearby where we would be ablating. And so the principle here is, like shown in this illustration, is that when it comes to thermal ablation like RF or cryoablation, there's the risk of transmitting that thermal energy to surrounding structures, whether it's the phrenic nerve or the esophagus, much lower risk theoretically, at least with PFA. Now, for the U.S. specific, we have several systems now available, and I've summarized the systems that are both available in the U.S. and under evaluation. So probably most common right now is the FARAPulse Boston Scientific system. Second most common is the Pulse Select Medtronic system. And then there are several from Biosense Webster, both either in development or for the case of the VariPulse that has just received approval this last week. Now, there are other systems as well, the Affera, which is now part of Medtronic, and others under development, including, as you all know as well, several in China. Now, I also listed as a key part of this on the right of the column, and this is important for the idea of potential for reducing fluoroscopy, is whether or not there's a dedicated mapping system. And as you can see, most of these now do. Some of them still don't, as you can see with the Medtronic Pulse Select system in particular. Now, when we look at clinical outcomes for PFA, before getting to the idea of reducing fluoroscopy, this is a summary of probably the three most important papers that have come out in the last couple of years looking at clinical outcomes. The first is the ADVENT study, which looked at the Boston Scientific system, and it was a randomized prospective study looking at their pulse field system compared to thermal ablation, which is either RF or cryo. And as you see here in the one-year freedom from AF outcomes, or atrial arrhythmias outcomes, there were equivalent outcomes. The safety was also equivalent, by the way. Similarly, although perhaps numerically a little lower one-year freedom from AF, the pulsed AF trial, which looked at the Medtronic system, had a 66% freedom from AF after 1 year. And then the initial manifest data, which I showed here, which is, I believe, around 1,500 patients or so, reported an 81% freedom from AF. But please note that in that study, over 2/3 of the patients only had one Holter monitor to look at AF burden. So I think it's probably underreporting AF freedom. Or recurrence, excuse me. Now, there are also several late-breaking studies that came out at the Heart Rhythm Society meeting this year. On the left is the Biosense VariPulse outcomes, which is a prospective single-arm study looking at their system with the variable loop catheter with very comparable outcomes in the mid-70% range. The Cardium Globe catheter was reported as well, which also had a relatively high in the low 80% freedom from AF in at least paroxysmal patients. And then the dual energy lattice, which is the Affera catheter, had somewhat comparable, although I would say a little bit numerically lower freedom from AF results. Now, you want to compare that, if I may say so, with what we understand with RF data, and I do believe our registry data may have probably the optimal outcomes data. So this is our multi-center prospective real-world evidence registry. We reported in Heart Rhythm at the Late Breaker last year, as well as published in Heart Rhythm Journal, about 2,500 patients using RF ablation, and in fact, most of these were performed without fluoroscopy. And with good outcomes monitoring, again, over 80% freedom from AF and atrial arrhythmias after 1 year. And I want to highlight also what's important to keep in mind is what is the real benefit of the safety that we worry about with PFA. I think we do think about the idea of lack of collateral or reduced collateral injury, but I think overall reported complication rates at least are very much comparable between various energy sources. So I think there's a lot of work still to be done to continue to improve those. Now, when we get to fluoroscopy now, so these are numbers directly extracted from some of those studies I mentioned. So as I said earlier, most cases in our registry, over 2,500 cases, over 2/3 of them, nearly 3/4 were zero fluoroscopy, and the remaining were under 2 minutes of fluoroscopy. In Manifest, the mean time was 12 minutes, and the maximum was 114 minutes, so that's very high, I think. Advent was 21 minutes, and Pulse AF was 26 minutes, so all quite high. And I think that's a step backwards. And why is that the case? Well, certainly some of it is because it's a new system and many people feel safe stepping backwards towards using more fluoroscopy, but I think there's also very intrinsic design issues with at least two of the systems, the Boston Scientific and Medtronic systems. Both are over-the-wire systems, which are a little bit, I think, easier to utilize when you use fluoroscopy, although I will go through how we do this without fluoroscopy. And also, as I mentioned earlier, many of these two, in fact, were not until recently integrated with a mapping system. The Boston Scientific has a new FARO-View mapping system. And then I say finally, at least the European data, Europe has very limited access to ICE, which is a critical component of zero fluoroscopy ablation. So of course, then as you're thinking about whether or not this is important to do, you have to balance the pros and cons. And I think that on the pro side of reducing fluoroscopy is, as I mentioned, the ELERA principle. And as I hope I can show you in some of our data, equivalent both safety and efficacy. But of course, against that is that it's an increased cost if you're adding ICE and as well a mapping system. And the procedure times are shorter when you don't use a mapping system or use ICE, as shown in some of the data. Now, what about its impact on safety and efficacy? I think that remains to be determined. So I'm going to spend just a few slides now going over a practical approach, what we do in our lab to achieve zero fluoroscopy when it comes to PFA systems. So this is sort of just a very simple, both a toolkit that you need and a workflow. On the left, the toolkit is basically everything that you already use in many countries. But with the, again, key requirements, as I mentioned on the top row, ICE, a mapping system, ablation system, and of course the transeptal system. I think optional, in my opinion, are a reference catheter and a high-density mapping catheter. Both can be very helpful, but are not, I think, required. In terms of a workflow, I'm not going to go over every step here, but as you can see, if you look through carefully on the workflow I mentioned, it's identical to what we typically do with RF ablation, except you're doing, of course, PFA ablation. So one important, I think, point I want to make as well in our experience over the past year or so is we learned very, very quickly is that especially in systems without a dedicated mapping system, you become much, much more reliant on ICE. So the need for ICE becomes even more critical when you're dealing with a PFA system, especially ones that do not have a dedicated mapping system associated with it. So I've shown some of these slides in previous talks over the years, but for the first practical steps for a zero fluoro approach, of course, we use ultrasound vascular access. We can advance our catheters through the vasculature safely, especially the ICE catheter, without using fluoroscopy by using the ICE images itself to guide you through the vascular system into the heart, as I've shown here. I'm not going to go over the details. But then the transeptal puncture is performed then entirely with guidance through ICE, as I've shown in some of these images, where you advance the wire under ICE, you advance the sheath over the wire, and then eventually you will do the drag down and the puncture, all using ICE again. I think we wait a second here. Well, anyway, so in terms of that workflow, as I mentioned, because each of these systems is a little bit differently, especially in terms of the wire-based approach versus whether or not they have a mapping system, I just want to go over the slight differences in the workflow when it comes to mapping system or dedicated mapping system or not, and wire-based system or not. So when you have an integrated mapping system, and we have in our lab, I think, a fair experience with the Biosense variable loop catheter, I think the workflow is more or less identical to the workflow that you typically utilize for RF ablation. Now the difference, of course, as I keep mentioning, is that when you have a wire-based system, how do you do things differently? So I'm going to go over some of that here. So for an ICE-based PFA workflow, first of all, the ICE visualization goals are to be able to much more clearly see the sheath and the catheter, and then as a result, the ensuring of tissue contact with the catheter, and that requires additional skill sets. and the specific ice visualization skill sets you need to be able to now become very good at seeing that wire and everywhere it is going in the atrium and everywhere else, and ability to visualize the antrum and ostium of all 4 pulmonary veins, and the ability to assess the tissue catheter contact at all of your ablation sites. So now the questions that I think I'm also working on and many centers are trying to decide is, do you have adequate views just from the right atrium, or do you need to think about placing the catheter into the left atrium or into the coronary sinus? I found it a little easier to actually go into the left atrium with the ICE catheter rather than the coronary sinus. You get better views, but I am aware that different centers that are trying to achieve this are taking different approaches. But so far, the majority of our cases, we are able to have adequate images from the right atrium. In fact, here are some examples. So these are all with the Boston Scientific device, which I think, again, is the most relevant for the idea of focusing on ICE view. If you are familiar with the Boston Scientific Farapulse catheter, it has 2 configurations, what's called a flower and a basket, and ablation is performed at each pulmonary vein in both configurations with several applications. And the key, again, is to be able to see the catheter as well as the wire as well as the tissue catheter contact. And what you'll quickly learn, which we quickly learned, is the left veins are actually very, very easy to see. So I've shown here on the left superior and the left inferior pulmonary veins with the catheter, as you can see here. The wire, in fact, is very easy to see as it traverses deeper into the pulmonary veins. The cursor is working here, but and on the left of each of these is the flower position. On the right is the basket position. And as you notice, if you especially scan through with your ICE catheter, you can see the tissue contact throughout the entire catheter tissue interface. And though I think my personal feeling is that any of these catheters, especially with these rounded configurations, but even with the flower configuration, it is physically impossible to have every electrode in contact with the tissue. So the concern about ablating in the blood pool, I think it's going to happen inevitably to some extent, but I think the goal of tissue contact is to minimize that. Now, on the other hand, the right pulmonary veins, as I've shown on the right here, I think this image is not running anymore, but on the right, on the right images, the contact is much, much harder to achieve. Let me see if I can just run some of these, or not the contact, but the images. So the right inferior vein is, I find, not very hard. So you can see on at least some of these stills, the image is very easy to see that there's good tissue contact with the inferior vein. Let me just maybe show you one of these if it can run. That's the flower position in the right inferior vein. Now the upper vein, the challenge is the upper vein has always been the hardest vein to view on ICE. And just a small practical tip is you have to always go up a little bit into the SVC, where you're closest to the superior pulmonary vein, and then a little bit of a posterior tilt to allow the full view of that vein. And usually when you do that, as you can see here, you can actually have an adequate viewpoint. Now, the last portion of my talk, I just want to spend a few slides discussing some of the evidence that we have that this is a safe and effective way to do this. Our personal experience has been primarily with the Varipulse and Farapulse devices, and we presented this just recently at the APHRS meeting at a late breaker. We did a sub-analysis of the ADMIRE fluoroscopy, or ADMIRE study. As you may know, the ADMIRE is the primarily US-based IDE study, which is a multi-center single-arm study looking at the variable loop catheter for PAF ablation using an integrated mapping system device. And what we did was to subdivide the patients into 0, low, and conventional fluoroscopy groups, and we looked at patient characteristics and outcomes. So the patient characteristics were similar across the board, no significant differences other than there was fewer patients who had failed antiarrhythmic medications in the completely 0 fluoro group. This is interesting looking at fluoroscopy use across the active sites in the study, and you can see there's a wide distribution. Probably what jumps out at people is there's one site in particular that seems to use a lot of fluoroscopy, but we were able to sort of subdivide those into those three subgroups. These are some of the procedural characteristics. You can see that there's a little bit higher use of double transeptal puncture in the conventional fluoroscopy group. That's probably an operator-specific issue. We tend to use more of the visualized sheath in zero and low fluoroscopy, and the procedure times are comparable, but in fact shorter when you're not using fluoroscopy, interestingly. And there's fewer applications of RF as well. The rest of the results are quite similar. And if you look then at the most important result, I think, one of the two most important results is freedom from AF across the three groups. And you can see that whether you use a lot, a little, or no fluoroscopy, the outcomes at 1 year are identical. And the second important result is complications. And interesting, we saw a non-significant trend toward fewer complications in the low and zero fluoroscopy groups compared to conventional fluoroscopy. So from this sub-analysis, we concluded that basically a zero fluoro approach within the mapping system using a PFA system is safe and effective. The next steps we are doing, that registry I mentioned, this is our registry, the Real AF registry. We will be activating our sites to use the VariPulse and other PFA catheters within the registry, so we'll be collecting data. And we have a separate registry that's already enrolled about 400 patients involving the FARAPulse system. So we hope to get more data on especially zero and low fluoroscopy use. So sorry for running a couple of minutes late, but in summary, fluoroscopy-based EP procedures are derived from vascular procedures historically, so that's not an ideal approach for EP procedures. Our technological advances, especially in ICE and mapping systems, have enabled zero fluoroscopy, but until recently the data and experience has been in RF. But zero fluoroscopy can and I think should be part of the PFA approach, and that's because the PFA catheters are now, most of them are integrated into a mapping system. And we also have improved all of our ICE skills over these years, and these will all, of course, improve as we gain more experience. And we have started to gather some data to show that this is both safe and effective. So I just want to acknowledge and thank our local group as well as our registry collaborators. Thank you very much for your time.